Okay. So this is beginning of our review session for exam one. We're having a discussion about gravidity and parity before we start playing our game. What is gravida?
Number of pregnancies.
Number of pregnancies. Does it matter how the baby delivered, gestation, anything?
No, it's
No.
just the total number of times.
It just matters that the pregnancy happens, right? Also, it doesn't matter if it's multiples. If it's twins, triplets, quadruplets, quintuplets, it still counts as one pregnancy, right? Parity is the number of what?
Preterm pregnancies born before 37 weeks.
Parity includes preterm pregnancies born before 37 weeks and also term pregnancies. So parity is going to include all deliveries after 20 weeks gestation.
Okay.
Okay. So that includes term and preterm for parity. All right. Anything that is delivered before 20 weeks is considered what?
Is that the miscarriage? Is that the A?
Hmm. And so it's considered an abortion. It's the A
Okay.
on our GTPAL. So if they terminated the pregnancy on purpose, then it still counts, as far as this goes, it still counts the same as if they have a miscarriage and it's a spontaneous abortion. Any delivery before 20 weeks is an abortion. It's an aborted pregnancy. Okay. So we aren't going to, for when we start talking about nulla gravida, multigravida, prima gravida, nulla para, prima, all of those, we don't count any of the deliveries that happened before 20 weeks in that.
Wait, so gravida is the total number of pregnancies, and then the P is from it's even term babies, just anything after 20?
The P is it when we're doing GTPAF, when we say parity, para is the number of deliveries after 20 weeks. It is parity.
Okay.
But if you break it down, GTPAL, that P is preterm.
Okay, that's what I'm getting confused with.
Mm-hmm. If you look at what I used in my class is I used this kind of a visual with an umbrella, and I can show this to you. I don't know if this is helpful at all. Um, so gravidity is the number of pregnancies, and parity is the number of deliveries after 20 weeks. So that's what's at the top here. Okay.
Okay.
So then if you do the full obstetric history GTPAL, the G is still gravida. But then under the umbrella of parity, you have your term and preterms. Okay. And then we also, even though A and L aren't part of our parity specifically, it still kind of all falls under that same umbrella when we write the term, all the numbers out. So
Okay.
if you have G and P, if I'm at work and they say we have a patient coming in, she's a G3P1. She's a gravida 3 para 1. I don't know if her last baby was term or preterm. I just know she's delivered a baby before. Okay.
Okay.
But so the P could be parity, and that's just your number of deliveries. Or if you're looking at the full obstetric history, then that P can be preterm. All right.
I have a
And then
question.
yes.
Sorry. During our class, I know that there was a big confusion on twins.
Okay.
So is twins considered one pregnancy only?
Correct. Twins
Okay.
only counts for one all the time until you get to the L. Twins is one pregnancy and it's one delivery. Okay, how many times did you fill the uterus? How many times did you empty the uterus, regardless if it's a whole litter or it's a single? And we get to the L in the living category, that's where we pick up the twin. Because then she might have delivered one delivery, but she has two living children. And so then she would be like a G1, P1, L2. Okay. Does that make sense? So in extending this a little bit further, then we start looking at the terminology. So if she's never been pregnant, never is null. Nulla gravida, never been pregnant. If she's had one pregnancy, that's prima. Prima is one. And if she's had more than one, she's multi. Okay. So nulla gravida is no pregnancies ever. Prima gravida is one pregnancy. And multigravida is multiple pregnancies. Okay. Now for parity, parity again doesn't count till after she delivers. So if she's pregnant right now, that doesn't count in her parity till that baby's born, and we know if it was before or after 20 weeks. And even if she's further than 20 weeks pregnant, we still don't count that baby in parity until it's delivered. So she could be, let's say that Patricia, because she's next to me on my screen, she's got a 3-year-old at home. And she's pregnant right now. Is she nulla gravida, a prima gravida, or a multigravida?
Multigravida?
She's a multigravida. Is she a nulla para, a prima para, or a multipara?
Prima para?
She's still a prima para because she hasn't completed this pregnancy yet. Okay. After this baby's born, as long as it's over 20 weeks, then will she be nulla para, prima para, or multipara after she delivers the second baby?
Multi-pair.
She'll be a multipara. Okay. Does that make sense? Any other questions about that? Okay. Any other concepts you guys want to touch on before we start playing the game?
Yes, I have a question. I am confused on the deceleration and accelerations.
Okay. So fetal monitoring, I feel like we could have a whole 2-hour class on fetal monitoring. It is a complicated concept. Okay. There's key points to take away. All right. So for fetal monitoring, the first thing we want to know is if we have a normal baseline. Okay. And I know that's not your question, but it'll come back to that. So what's the normal baseline for fetus?
It's 110 to 160.
110 to 160. And when we look at the tracing, we're looking at how long, like where the squiggly line is hanging out most of the time. And that's our baseline. Okay. We want it to be between 110 and 160. We also look at something called variability. How much does the line squiggle? Okay. And the squiggliness of the line gives us an indication of how the baby's doing. All right. So if you have a line that's just got tiny squiggles, less than 5 beats of variation, that's minimal variability. Minimal variability might be fine. Babies that are sleeping can have this little minimal line, but also that can be a sign that the baby's becoming hypoxic. So we don't totally know when you have minimal variability. We're not totally sure the baby's fine. We're not necessarily worried, but we're watching it closely. If we have good squiggles where the variations are between 5 and 25 beats around the baseline, that's moderate variability. That's really reassuring. Okay. So, and there's a couple other variations to that too, but those are the two main ones that you might see is minimal and moderate on the variability. Okay. Then we get to accelerations and decelerations. If the heart increases more than 15 beats above the baseline, and it lasts for longer than 15 seconds. That is an acceleration. With an acceleration, that is a good finding. That's another thing that babies can't do if they're not well oxygenated. So if you have an acceleration, I'm trying to see if I can show you a picture. If you have, I'm going to find, I have a PowerPoint that has like better pictures. I'm going to just grab them while I'm talking to you. If you have accelerations on the tracing, that's very reassuring. So if you have moderate variability and accelerations, that baby is doing really well. Okay, we know that baby is well oxygenated. We don't have any concerns, right? If your baby is having decreases, that's where the decreases get a little bit confusing, a little bit complicated. But if we're having decelerations, then we're going to look at what kind of decelerations that we're having. And that's going to help us know how worried we are and what we need to do about it. So I'm just going to share my screen for a second, just because I have in this one PowerPoint, this isn't one I use for class, but it has some good pictures in it of what I'm talking about. So this one, for variability is those little fluctuations around the baseline. And you see this line right here is not very, it's kind of flat, right? There's not big variations here. That's minimal variability. That's the baby that might be taking a nap, but also might be hypoxic. I'm not sure. I also might have given mom fentanyl and the baby's also kind of sleepy. All right. Moderate variability, this is the next one I talked about. See how much more squiggly this line is? Okay, that's good. All right, and then accelerations. So here's accelerations. I'm going to zoom in on this picture. So when we look at the tracings, we're looking at, and you guys don't have to read tracings. Like you won't have to see a picture of a tracing and go, oh, that's moderate variability. But just so that you understand what we're talking about when we say more than 15 and more than whatever, this is the little graph we look at. And the graph has, in the lines moving up, they're each 10. And then on the boxes moving side to side, they're each 10. So 10 beats going up and 10 seconds each going across. For an acceleration to count, it needs to go up by at least 15 beats and last at least 15 seconds. So if we look at this hill right here, this increase, this is our baseline. This is where the heart rate's hanging out the most. And then we count 10, 20, 30. It went up by 30 beats. And then we count across 10, 20, 30, 40, 50 seconds. It lasts 50 seconds. So this is an acceleration.
So that's good,
Accelerations
right?
are really good. They're really good. I'm so excited when I see accelerations on a tracing because I know that baby is neurologically intact and is well oxygenated. Okay, the whole point of fetal monitoring is to determine if our baby is oxygenated. A tracing like this right here, where we have a normal baseline, because if I zoom in and look, this baseline, here's 120, 130, 140. So this baseline's at about 140, so it's a normal baseline, moderate variability, accelerations. This is reassuring that this baby is doing well. Okay. Now, when we get into decreases, let's look first at early decelerations. Early decelerations mirror the contraction. So when the contraction happens, and you see the blue shaded area in this picture, okay, you can see where the contraction starts down here, and you can see where the contraction ends. And then up here is the fetal heart tracing, and you can see when the contraction started, the fetal heart rate went down. And then when it comes back up to the baseline here, that's also right when the contraction's ending. So these are happening at the same time. They're mirroring each other. This happens when there's pressure on the baby's head during the contraction. So this is not something that will cause hypoxia for our baby. This isn't concerning. We just monitor this. This is actually probably a sign of progress that the baby's coming down further in the birth canal. And so we call these early decelerations, even though they're really kind of on time. All right. And you can see in this picture, all three of these, they happen exactly the same. They're mirroring each other. This is head compression. This is normal. Okay. Let's look at late decelerations next. These are the ones we worry about the most. Okay. So down on the bottom of the graph, you see where the contractions are. And then up here, you can see the heart rate, and then you can see where it goes down. And so the shaded area is shading where the deceleration is, so you can follow it down and see how it lines up with the contraction. And you can see that this deceleration started after the contraction was already at its peak. And this deceleration didn't come back to baseline until well after the contraction had ended. These, if the word after is in your sentence, it's a late deceleration. It happens after the contraction starts and it ends after the contraction ends. And this one, guys, is the most worrisome. All right. This is, when we look at veal chop, this is a sign of placental insufficiency, or you might also see it written as uteroplacental insufficiency, where we're just not getting enough oxygenated blood through the uterus to the placenta to give the baby the oxygen it needs. And so this drives hypoxia for the baby. This is dangerous. Okay, these are late decelerations. The other type of deceleration we have are variable decelerations. And the word variable sounds like variability, which is what we talked about with the squiggly line, but it's different, okay? Variable is because the timing of these are variable. It doesn't matter. The timing for variable decelerations does not matter how it times with a contraction, because the problem that's causing it is not the contraction. Okay, the other ones with early, we're getting head compression during contraction. With late, we're not getting good blood flow during the contraction. But with variables, the problem is cord compression. And so it's possible that the contraction caused the pressure on the cord. But it's also possible the baby's squeezing his cord, or he rolled over on it, or something like that, and that's what caused it. And with variable decelerations, they have an abrupt onset. They happen quickly. So if you see keywords that say like sudden or abrupt, you see how this drops really fast? And then it comes back to the baseline really fast as soon as the pressure relieves off the cord. And so it makes a kind of V shape. And in this one, it looks like it times with the contraction. This one looks like it times with the contraction. This one doesn't. See, the timing might not be related to the contraction at all. It's really only caused by whatever is putting pressure on the cord. All right. These are not as worrisome as late decelerations, because as soon as the pressure relieves from the cord, they're going to start getting that good oxygenated blood flow again. They're getting oxygenated blood from the placenta. There was just an interruption in the blood flow while there was pressure on the cord. So these ones, we still want to kind of try to get the pressure off the cord. So a good first thing to do is to move the mom to see if we can shift the baby. All right. But this isn't going to be the one that I'm worried about causing hypoxia for. Okay, so that's what they all look like. That's what they all do. Then we think about veal chop. So with veal chop, the word veal, you write it in a line. And then the word chop, you write it in a line next to it. And then in my graph, I have the word mine next to that, because that reminds us what needs to happen or what we should do. Okay, so for V are caused by variable decelerations. And the first letter of chop is a C. So that reminds us that it's cord compression. All right, variable decelerations caused by cord compression, we should move them up. Okay. And then in the capitals here, you can see the type of words you might see that would remind you that it's a variable deceleration. So if the decrease has an abrupt onset, that's probably a variable. The E of veal chop is early decelerations. Early decelerations mirror or happen at the same time as a contraction. They're caused by head compression. And for the mind part of what we should do, intervention isn't needed. So if you have something that is a normal finding, early decelerations are normal, what would be the priority nursing intervention for an early deceleration?
Nothing. We just kind of encourage the mom to keep going, I guess. I don't know.
Yep, and document the finding.
Yes, of course.
I remember when I was in nursing school and whenever I saw document the finding, I was always so stuck on that. I'm like, of course I need to document this, but that's not the priority unless there isn't another priority. If there isn't another priority, all you need to do is document it. Okay, so for early decelerations, reassure the parents, let them know that their baby's doing well, document the finding. Okay. So intervention's not needed. Accelerations, we looked at that. Those are those increases that are at least 15 beats and last at least 15 seconds. And in parentheses, I put in here because that it's if they're over 32 weeks, because if the baby's less than 32 weeks, then in order to meet criteria for an acceleration, it only needs to be 10 beats by 10 beats. But I don't necessarily think you guys get asked that. They give you that information so you know that if the baby is younger, if it's less than 32 weeks, it doesn't have to do 15 by 15, it can do 10 by 10. But any baby over 32 weeks is 15 by 15. So those are the numbers to know. Okay. This is a sign of oxygenation. Remember, if we're having accelerations, that's great. So there's nothing to do. So what do? We document the finding or reassure the parents or whatever answer says this is normal, this is fine. Okay. Late decelerations. That's this guy that looks really bad, right? Because it happens after the contraction starts and comes back to baseline after the contraction ends. Late decelerations have that keyword of after. In veal chop, it's the P for placental insufficiency. These are dangerous for the baby. This is going to drive hypoxia. So the main things we think about for this is how do we perfuse the placenta and what could be happening with her that is affecting her perfusion to the placenta. So it could be her position. Remember supine hypotension, if they're on their back, the baby's putting pressure on the vena cava, it causes her blood pressure to go down and she doesn't perfuse her placenta well. So that can cause late decelerations, that can cause a hypoxic baby, and that's why we teach moms to turn on their side. Or even if we lay them on their back to measure their fundal height and they don't feel well, we just quickly are getting them off their back. We don't really want them laying on their back, okay? So consider position. And position's a good first thing to do for either variable or late because it's quick, it's easy, it's non-invasive. So if I move the mom on variable, I'm taking pressure off the cord. If I move the mom for late, maybe I'm perfusing the placenta better. It could be blood pressure. If her blood pressure is low, we're not perfusing the placenta well. And does anybody know something that we do purposefully to women in labor that can cause them to become hypotensive? Any idea? She will ask for it.
Making
Epidural.
The epidural. Okay. So an epidural can cause that blood pressure to go down. And if the blood pressure goes down, then it affects perfusion to the placenta and can cause late decelerations. And then contractions can also cause late decelerations because every time, I have it in here, I think I have a picture of this. Every time that the uterus contracts, during the peak of the contraction, there's no blood flow coming to the placenta. All right, and so if we don't have normal blood, we have normal blood flow between contractions, and then as the contractions building, we have less, and then we have no blood flow during the peak, and then we have less, and then we're back to normal again. If these contractions are right on top of each other, we're not getting good blood flow in between the contractions to exchange out the waste and to bring in good oxygenated blood to help sustain the baby during the contraction. So if she's having too many contractions, they're too close together, that also can cause her to have late decelerations. And so that's another thing that can cause placental insufficiency. So when we think about that, then to think about what we need to do, I like the acronym POINT because position is first. Position's a good first thing to do. Okay, change your position and see if we get pressure off the vena cava, if we get better blood flow to the placenta. Oxygen is always a choice, and we still teach it, and it still shows up on NCLEX, but in practice, oxygen is not the first priority. And let me tell you why. If I'm not getting good blood flow through to the placenta, it does not matter how oxygenated I make that blood, because it's not getting through the placenta to the baby anyway. So oxygen's really more to make the nurse feel better, like she's doing something. All right. And it is helpful if mom is hypoxic. If she has a condition that's causing her oxygen saturation to be low, oxygen is a great idea. But it's not really a priority for this. But if there's not any other choices that fit what your patient needs, you could always select oxygen. But I wouldn't pick it as a first choice. So position for sure. IV fluid, if her blood pressure is low, let's give her some IV fluid to support her blood pressure. And that's even what we do with epidurals before we give the epidural to help support the blood pressures. We give a fluid bolus. Okay. The N is for notify. If I'm having late decelerations, we need to notify the provider. They might need to order tocolytics, which is the next thing on our list to slow contractions down. They might need to consider doing a C-section because this baby is not getting good oxygen. The baby is showing signs of hypoxia with these late decelerations. And so notify the provider. And then the T is for tocolytics. Tocolytics are medications that slow contractions down. We can also use T to turn off the oxytocin. If we're giving her oxytocin or Pitocin to augment her labor and her contractions are too close together and we're having late decelerations, turn it off. Okay. Anybody know what the tocolytic of choice is here? What we could use for this patient right now to help slow her contractions down?
Is it terbutaline?
Yeah, good. It's terbutaline. All right. So we can give her terbutaline and it would slow her contractions down. So the good first thing to do is position change. Then we can do IV fluid. We can turn off the Pitocin if we need to. We can give terbutaline if we need to, and we need the doctor looped in case they need to do a C-section. Okay. Is that helpful?
Yes, thank you so much.
Okay. Anything else before we start our game? That's it? All right. The game I have for us today, hold on, I gotta put my PowerPoint away now. What are we doing here? Oh, I get it. All right, so this game goes through a platform called Blooket, which is like Kahoot. The difference with this one of the differences is that I can give you a link and you can play it on the device you're on and still see the questions on that device. You just won't be able to see the Zoom, but you can still hear it. Or you can, it's going to also give you a QR code, so you have a choice. Okay, so you can scan the QR code that's right up here on the left corner. You can go to play.blooket.com and enter in this code, or else I'm also in the chat gonna drop a link, and you can, if you just are playing on one device and on Zoom on the same device, you can use that as well. Also, guys, for those of you that have just your first name showing, it's really helpful so that I can let your instructors know you came if you put your last name in on your Zoom. I scare you. My dog was asleep on the floor and I moved a table over so I can put my coffee there, and it totally scared her. She doesn't usually get invited into my office when I'm teaching, so she was enjoying it. Catching a
I put
couple of days.
the code for the game, but it says no game when I try to go next.
Did went to play.bluekit.com?
Yeah, and I put the code and then it says enter nickname.
Yep.
And it won't let me. It comes out as no game in red. Maybe if I
Well,
put join. Sorry.
yeah, maybe try that.
No, it's no. Let me try to go
Mine
back and
says
read.
waiting on host.
Yeah, that one is right. That means it's just waiting for me to start the game.
Sorry, I'm gonna enter the code in again and see. 50276. Okay. Okay, there we go. 20K. Got it. Thank you.
I apparently muted myself. When the cervix of a woman in labor is dilated 9 centimeters, she states that she has the urge to push. Which action should the nurse implement at this time?
Mine still won't let me answer. It still says waiting for host.
That's weird. Do you want to try to, sorry, I was reading the chat. Do you want to try to go out and come back in?
Sure. Can I get the QR code back or?
Oh, that's true. No.
Okay, I can just do
But
it
you
on
can go to Bluekit dot, it shows the ID only. You could use the link in the chat. I think if you go to play.bluekit.com and then enter the ID code on the top right. The time is not, we can't increase the time once the game has started. Plus we have 45 questions, and so we'll.
It's not letting me do it. It's okay. I can just watch on the Zoom.
Oh, I want you to be able to play. You tried to go to play.bluekit.com
Yes, ma'am.
and then it didn't ask you for the ID number.
It just says waiting for the next question. It doesn't even.
Well, maybe it's going to work now. Let's see what happens. All
For
right, so let's talk.
I think we need more time to
I know.
answer questions.
So the game isn't going to let me increase the time, and because we've already started the game. And I did think it was set for 20 seconds, but that's okay because we're mostly going to pause and talk about them anyway. We're going to stop at each one and discuss it. So if we don't get a chance to answer, it'll be okay. All right. So she's 9 centimeters dilated and she has an urge to push. Okay. Is it okay for her to push right now?
No,
No.
not until
No.
she's 10
Right.
centimeters.
If she pushes and and the cervix isn't all the way dilated, it can tear the cervix and cause it to bleed. So we don't want her to push yet. So in this, the choices, we don't want to have her push. We could start talking about pushing techniques, but right now, if she's 9 and having this urge to bear down, she's not like in a place for education. Okay, we need to keep her in control and help her not bear down. And so having her pant and blow during contractions until she's able to push is a better choice to help her stay in control. Okay. The nurse notes the presence of accelerations on the fetal monitor tracing. What is most appropriate? Okay, accelerations. So we talked about this before we started the game. If we have accelerations, is that good or concerning?
Good.
Good.
It's good. So if something's good and we don't need to intervene at all, what should we do?
Document the findings.
Document the findings.
Document the finding, reassure the parents. Okay. For this patient having acceleration, she doesn't need a position change in order to improve her tracing. Her tracing's great. Nothing else to do. Tell her good job. Which would not be recommended advice for a pregnant patient with constipation? Okay, good. So we would definitely encourage ambulation, hydration, high fiber diet, like complex carbs, stuff like that. We would encourage her to not try to hold it, to try, every day to kind of just sit and relax and let it happen. It's so great now we have our phones. We can just kind of sit and do our thing for a little bit. We don't want her working hard and straining, but that in and of itself wasn't the better choice here. The one, because that's not a preventing constipation thing, that's the normal BM thing. But mineral oil, castor oil enemas are not routine for preventing constipation or for coping with constipation unless it's prescribed by a provider. And castor oil, we typically tell women not to use. Some women use it as a means to go into labor. And it
Yeah,
causes
can't that cause
diarrhea.
contractions?
It can cause contractions and it can cause diarrhea, and so these are all things we would not recommend women do. We would recommend relaxing to poo. We would recommend exercise, ambulation, hydration, all the other things on here we would recommend, but we wouldn't want them taking things unless it was specifically prescribed. And castor oil is also horrible, I feel, for pregnant ladies. When managing non-pharmacological pain management, the nurse educates the client about a technique to prevent the painful stimuli from entering her brain. Okay. So focused breathing is a great non-pharmacological pain management technique. It is. The one that is specifically keeps the nerve impulses from getting to the brain is gate control. Gate control is based on the idea that if you have a positive impulse that's going to the brain, that nerve will not carry the negative impulse. So these are going to be things like massage and touch and those kind of things that keep positive, it stimulates positive chemoreceptors going to the brain so that we don't get as many of the negative going. The first maternal perception of fetal movement, commonly felt as fluttering, feeling usually between 18 and 20 weeks gestation. Okay, so this is quickening. Okay, this is her first perceptions of fetal movement. What is lightning?
That's when the baby drops down.
That's when the baby drops down. So it's lightning is really kind of happening at the same time as engagement because the baby's engaging in the pelvis and dropping down closer to those ischial spines. Okay. What sign of pregnancy is quickening? Presumptive, probable, or positive?
It's probable, right?
Presumptive.
How many think presumptive? How many think probable? How many think positive? Only like 4 people voted. The truth of this is that quickening is presumptive. Any idea why?
Because
Because it
it's
can also
subjective.
be like, it's not, I got them mixed up. So it's not a for sure thing. It could also be like gas.
Yep, it's subjective information she's telling you. It could also, like you just said, it could also be gas. I don't know what she's feeling. Okay, so quickening is the term for those first flutters that she feels, and this is a presumptive sign. Gravida refers to which of the following descriptions? Good. All right. The number of times she's been pregnant, that's gravida. Doesn't matter if this before, after 20, whatever. It only matters that the pregnancy happened. The physician has documented the presence of Chadwick's sign. The nurse determines this sign indicates what? Okay. We've got a lot of different ideas for this. All right. So Chadwick's sign is the bluish discoloration of the cervix and the vagina that happens with pregnancy because of the increased blood flow and congestion in that area. Okay. Pardon me. What sign of pregnancy is Chadwick's sign?
Probable.
Well,
Sorry, I didn't hear which was it?
Probable.
Is probable. Any of the things that have the word sign in it are things that are objective that you can assess. Chadwick sign, Hagar sign, McDonald's sign, Goodell sign, those are all probable signs. All of them except Chadwick are types of softening. Softening of the cervix, softening of the uterine segment, those things. but Chadwick is the bluish discoloration. A pregnant client states her last menstrual period was 12/1/2018. She has been pregnant 2 other times, delivered twins at 37 weeks and 1 day, who are now 2, and had a miscarriage at 8 weeks. What is her GTPAL? I'm going to try to pause it as soon as it ends here. Oh, I was hoping it wouldn't show the answer. Okay. So I think we hear about her a couple times in this game. So this one wants to know her GTPAL. So what's her G?
3.
What are we counting?
Her pregnancies.
Yeah, and so from the scenario, where are you getting 3?
She's pregnant,
Good,
and
she's
she's been
pregnant now.
pregnant 2 other times.
And then the twins count as 1, and then she was pregnant with the one that was a miscarriage. So she's pregnant currently, the twins, the miscarriage. Okay, so G is 3. How many of her deliveries are term?
1.
1.
1. And that delivery this term was?
37.1.
37.1 weeks.
Yep. Good. So that's the twins. It counts as 1 delivery. She was over 37 weeks, so it's a term delivery. How many preterm deliveries?
0.
None.
None. How many abortions?
1.
1.
The miscarriage. How many living children?
2.
2.
2. Yep, for the twins. Okay. So this is a prime example of where we picked up that twin under the living category. She's G3, T1, P0, A1, L2. If you saw it just as gravidity and parity, what would she be? What's her parity?
G3, P0.
So for parity, she's a P1 because she's had 1 delivery, right? So gravida 3, para 1, living 2. All right. What's using Nagel's rule? What's her estimated due date on this current pregnancy?
12, 11, 10, 10 and 9, 9.
Subtract also 11.
9, 8,
So would it be
19. 9, 8, 19.
9, 8, 19.
Yeah.
I agree. Okay. How did you get that?
Go back 3 months, add 7 days, and add a year.
Perfect. Okay. Any questions about this?
So your GTPAL would be one thing versus just your G and your P.
Yep. This girl, is she a nulla gravida, a prima gravida, or a multigravida?
Multi-gravid?
Mm-hmm. Yep, she's had multiple pregnancies, right? She's had 3 pregnancies. Is she a nulla para, a prima para, or a multipara?
Multipara.
Does anybody else think anything else, or do we think she's a multipara?
Delivered twins. Right now too.
no? Because she's only had 1 pregnancy with living offspring, right?
She's had 1 delivery past 20 weeks. Okay, so for parity, we're talking about deliveries.
So it'd just be prima para, right?
Right. She's a prima para. She's only had 1 delivery past 20 weeks. All right, so she is, even though she's got twins, she's pregnant now, she has all this history, she is a multigravida prima para. Okay, and when she delivers the pregnancy that she has now, then we'll It depends if it's before or after 20 weeks, but if she's after 20 weeks, then she'll become a multipara. But right now she's a primipara. A prenatal nurse recommends folic acid supplements to a pregnant client. Which of the following defects can occur if the neonate as a result of folic acid deficiency? All right, folic acid deficiency can cause neurotube defects. So spina bifida, meningoceal, myelomeningoceal, anencephaly. This has to do with the neurotube goes from the brain down to the bottom of the spinal cord. And so it affects anything along that track. Okay, so folic acid, we actually have them take it before they get pregnant because the neurotube closes at 9 weeks gestation. Okay, so if she is lacking in folic acid, then that's where we can see those issues. That's not the only thing. You guys know how we could test, how we could have an indication that a patient might have a neural tube defect?
Like through the blood work?
Isn't it like in a scan that they can see like the opening or the closing of the spine or something?
So that's true. So blood work is true. We do alpha fetoprotein. Okay, with the alpha fetoprotein, is it high or low with neural tube defects?
Yeah, it's
And they're
supposed to
doing
be
No.
I think it's
Hi.
in here and
It would be high with neurotube defects. What would and the other one, if it's low, what could it be with alpha fetoprotein?
Down syndrome?
Down syndrome.
Down syndrome. And then Scarlett, what did you say?
Down syndrome?
Oh, I thought you said something else.
Oh no.
Okay.
It's low with Down syndrome and it's high with neural tube defects.
Yep. So the alpha fetoprotein would be an indicator if it was high. We could, for the scan, we could see it on ultrasound, potentially, depending on significance. Okay. How could we definitively diagnose a neural tube defect before birth? Also Down syndrome, another way to definitively diagnose Down syndrome too.
Don't they do an ultrasound of the, or no, they do the blood work, right?
The blood work can give us an indication and the ultrasound can give us an indication, but how would I know for sure?
Is it an amniocentesis?
An amniocentesis. Okay. But amniocentesis, how do we do it?
That's when you put the needle and like take out some of the fluid and I guess test it under a microscope or something.
They take the fluid out, yeah, and then they can look at the chromosomes and everything. So they can detect a lot of different things with an amniocentesis, but that's very invasive. What kind of things could happen with an amniocentesis?
Can a miscarriage
They
happen?
can like have leak like oh my god, like your water break, like burst the sac or something like that.
Yep. So we could get, it has a risk of infection, it has a risk of causing miscarriage. We also can do amniocentesis later in pregnancy to determine fetal lung maturity, but then at that point we're past this time of miscarriage, but could also cause preterm labor or water to break and things like that. So it's an invasive procedure. So it's not the first thing to do, which is why like we would do the alpha fetoprotein first, then we would move to an ultrasound and then decide if we needed to do the amniocentesis.
I have a quick question. With the alpha fetoprotein, you're testing it obviously from the mom's blood. So that's like it would be what's coming back from the baby to the placenta, like the weight. It's coming back from the waist.
That is a really good question, and I'm not sure exactly what the answer is to that.
Okay, don't worry. I'll ask ChatGPT later.
Yeah, I'll ask ChatGPT. You guys be so careful about ChatGPT. There are so many things, like I'll plug something in. I'm trying to just, get a simple whatever. And I look at it, I'm like, that's not even correct. Some of the things it spits out about OB is ridiculous, just so you know.
Yeah, it's happened to me before for sure.
Mm-hmm. I'll type back, I'll say, this is not correct. And it'll go, oh, I am sorry. All right, which assessment data can be determined by examining the fetal heart rate strip from the electronic fetal monitor? Okay, this is really going to give us the best indication of if our baby's oxygenated. That's the whole point of fetal monitoring. All the stuff, all the things that we are learning about, and all the stuff we do in practice is just making sure our baby's not hypoxic. Okay. It can give us an idea that maybe progress is happening. Remember when we talked about early decelerations and there's head compression, so she probably is making progress, but that's not really a definitive thing. It's just a possibility. But oxygenation, if she's got moderate variability in accelerations, it is definitive that we're well oxygenated. Okay. And if we're having late decelerations, it's definitive that we need to intervene or that baby will be hypoxic. A pregnant woman has been admitted to the birthing unit having contractions for several hours, which are now 5 minutes apart. Her cervix is 580 and the baby is ROA at -2. Her membranes are intact. Based on this data, the most appropriate nursing intervention would be to do what? All right, there's so many things to talk about with this. Besides the fact I noticed it has a typo. All right, so she comes to the birthing unit, she's contracting, her contractions are 5 minutes apart. Okay, is she in labor? Just based on that information. Hold on, before you've checked her cervix at all or anything, if she comes in, she's having contractions every 5 minutes, is she in labor?
I mean, if they're actual contractions and not Braxton Hicks, but I guess you don't know until you assess.
You don't know. And how do I know if they're contractions that are labor contractions?
If they get more intense and if she's dilating.
So if she's dilating is the key to that. Okay. The way to really know if someone's in labor is cervical change. Is her cervix dilating? Is her cervix effacing? Is it opening? Is it getting thinner? Okay, that's how we really know. All right. Now, as far as true labor contractions versus false labor contractions, if they improve with activity, they're false labor. If they are felt up high, those are usually false labor. True labor contractions are going to continue to worsen and get stronger with activity and also worsen with comfort measures. So if she's taking a jacuzzi or an ambulating and they're getting worse, it's probably true labor contractions. If she's feeling them in her back and they're radiating down to the very front lower part of her belly, those are probably true labor contractions. But the way I'm really going to know if she's in labor is to check her cervix. So we checked her cervix and she's 5 centimeters dilated and 80% effaced at -2 station. Do you think that's labor?
I don't know because you can sit with your cervix at 80% effaced and you can also stay dilated. I mean, it can go either way.
And Daniela, what's your question?
If you could ask your question again.
So the question I asked was, she's 5 centimeters dilated, 80% effaced, and -2 station. Is she in labor?
Yes.
Okay, she thinks yes. Anybody else?
No, not until 6 centimeters.
So that's a good point as far as when we think about active labor, because active labor before that is considered latent, right? Active labor starts at 6. And Patricia's also, she's right that you can be very effaced and be dilated and not necessarily be in labor. I will say if she's 5, she's probably in labor. Typically, people might be walking around in life being 2 or 3 centimeters dilated. Typically, if they're 4 or more, well, sometimes I still see them 4 if they've had babies before. But typically, if they're 5 centimeters, she's probably in labor.
And what group?
Okay. But you can be walking around doing your life things and be 90 or 100% effaced, be 2 or 3 centimeters dilated. That could
She's
happen.
been busy all day today.
Okay. So for this girl, we have limited information to really make a good decision. All right. But right now, she's 5. This ROA, does anybody know what this means? The fetus is in the right occiput anterior position.
With baby's positioned already, when it goes through the birthing canal.
Okay. So the
Does it
head's
mean
down.
like head down? Yeah.
Yeah. The head's down. And the right occiput anterior means that the occiput of the baby is towards mom's right anterior. So mom's right side, and then it's towards the front of the anterior part of her pelvis, which basically means the baby's facing more towards her back and a little bit angled to the right. Which is a perfect for vaginal delivery. All right. So she's 5, she's 80, she's -2, her baby's head down, her water's intact. Of the choices here, I'm not going to send her home, okay, at 5 centimeters dilated. If she was less, I might consider sending her home if her cervix didn't change. So the other night, there was a patient that came in, and she was 3.5 centimeters. And she was having contractions, and they thought she probably was in labor. And then they kept her and they monitored. Her baby had normal baseline, moderate variability, accelerations, no decelerations. She ambulated. We didn't do the jacuzzi, but she ambulated for a while. And she was 3.5, they said. We rechecked her cervix a few hours later, and her cervix was the same. That girl got to go home because her contractions were Braxton Hicks contractions. They weren't making cervical change. Okay, but this girl in this scenario, being 5 centimeters, she's probably in labor. I'm not going to send her home. I'm going to encourage her to do non-pharmacologic comfort measures and continue to monitor her. I'm not going to encourage her to go to bed. Okay, we want to keep her upright and moving. That's going to help with fetal descent. And I'm not going to, and so that's both of these. Encourage her to rest in bed and tell her to try to take a nap. I would encourage her to ambulate or to get in the tub.
I have a quick question. For the ROA, how do they know that? Is it like just through feeling, or like how do they
It's
get?
mostly through feeling. Sometimes, like on the
Yeah.
ultrasound, they can put an ultrasound on, and if you see eye sockets, you know
Right,
that the baby is occiput posterior because the baby's head is looking out. But most of it's by feel. The baby has on their head, they have those suture lines and the fontanelles. And so when you are checking, you can feel that. So I can show you, I have a picture real quick of that right here. Oh, I guess I can't zoom in. Down here, this baby, do you see the lines on the head? So when the baby, when they do a vaginal exam, they feel for the fontanelles and the suture lines, and that's how they can tell which way the baby's facing.
Amazing. Thank you.
I know, it's pretty crafty. The things you can just tell with your fingertips.
Yeah, because
Right.
I always see like all this stuff, and I'm like, well, how did they know that? You know?
Yeah, that one is all by feel. unless they see eye sockets on ultrasound. So for this one, she's going to stay. We're going to do ambulation jacuzzi. If she was less dilated and she wasn't changing her cervix, she might go home. If she was more dilated and really pounding out contractions, she might want to start asking for pharmacologic pain management. But right now, she's great for non-pharmacologic, which is not one of the 5 Ps. All right, we need to work on this. You guys are all over the board on the 5 Ps. All right, our 5 Ps. These are factors that affect labor. Pain is not one of them. Okay, what are our 5 Ps?
Passageway, passenger.
Passageway, passenger,
Power,
power.
position, and sight.
Good. Okay, so for the passageway, what is included in the passageway?
The canal.
Okay.
So
What
the
else?
pelvic shape.
Yep, good. The shape of the pelvis. So if we have like a gynecoid pelvis is the best one, right? The birth canal, the cervix, okay, are all part of the passageway. This is what baby's coming through to have a birthday. The vagina, all of that. What's included in the passenger?
The baby.
Baby.
The baby.
In the baby's position.
And everything that has to do with the baby's position. So is the baby longitudinal or transverse? Do we have like a flexed attitude, which is what we want? Do we have occiput anterior versus posterior, which we kind of talked about with that last question? All of those are related to the passenger. The placenta is also considered a passenger. Okay, but it's not really, it's kind of the end of delivery. So that's not a big part of it, but it's still considered a passenger because it's the other thing that's going to come through the passageway. What about power?
That's the contractions.
Yep. And what else?
The pushing.
The pushing. Good. What about psychological response or psych?
Isn't that like the
Tolerating.
emotional mental part?
How's she coping? And part of it's how she coping with the labor itself, but it also can be kind of where she was mentally coming into this process. Sorry, there was just a really scary noise that just happened. All right, so so her mental status, it could be past experiences. If she had a really traumatic birth last time, if she has a history of sexual abuse, if she doesn't have a good support system, there's all sorts of things that play into the psych part. Okay. And then the position for mom. The P for position is mom's position. So things like upright positioning helps with descent, things like that. Okay, positions that we might put her into that are restful, positions we might put her into to help labor progress, positions we might put her into like hands and knees, things like that. Okay. So on the game, it had psychologic response is a 5P, position of the mother is a 5P, power is a 5P, pain is not. So when it says which one is not, pain is not. But we look at coping under our psychologic response. Which is not a probable sign of pregnancy. Okay, so for probable, anything that says sign is probable. So Chadwick's sign is probable. okay, because that's an objective thing we can assess. Okay, the pregnancy test is also probable. Okay, we can assess it, we can test for it. If she has HCG in her urine or her blood, she's probably pregnant. All right. Braxton Hicks contractions, we can assess it. All right, we can put our hands on her belly, we can feel her uterus tighten. But in order for it to be a positive sign, it has to come from the baby. Braxton Hicks contractions are coming from the mother. And there's other things her uterus could be contracting around. So that's also probable. The fetal movement palpated by the nurse, this is coming from the baby, and I'm assessing it. So when we talked about quickening, I can't assess quickening. She tells me I feel this, and I go, okay. All right. But if she's like anybody that's had babies before, think about like towards the ends of pregnancy when your baby, you can actually like see it through your belly, your baby's moving around, you put your hands on your belly, you can feel those kicks. If I can put my hands on her belly and her baby's kicking me, she's definitely pregnant because her baby's kicking me. I felt it. So this is actually a positive sign in blue. So that was why that was not probable. What purpose of placental functioning should the nurse include in a prenatal class? Okay, good. All right. The placenta exchanges oxygen and nutrients and waste between the mom and the baby. Okay, that's good. What assessment tool is used to evaluate fetal well-being and assess for potential fetal compromise? We talked about two of these in great length already, so you should be able to narrow it down. Okay. So the amniocentesis we talked about. I misread this. I thought this was said alpha-fetoprotein. So amniocentesis we talked about. It's not going to give us indication of fetal well-being. The amniotic fluid level index lets us know how much amniotic fluid is in there. Okay, that's not necessarily an indicator of fetal well-being or fetal compromise. It is something that we keep track of, and there's other reasons why that matters to us, but not for this. Percutaneous blood sampling is something we can do in utero if we need to check things like fetal anemia and stuff. But the biophysical profile is going to be the one that is really our big tool for evaluating fetal well-being. So when we talked about fetal monitoring earlier today, we talked about what is reassuring on the tracing. Pardon me. And the fetal heart tracing, we do what's called a non-stress test. And a non-stress test is when we put her on the monitor and we watch for 20 minutes and we look for all those things we just talked about. We look at the baseline, we look at variability, we look at accelerations, we don't want to see decelerations. The non-stress test is one part of the biophysical profile. Any idea what else we do with a biophysical profile to help us determine for sure if our baby's doing okay? If our non-stress test isn't conclusive, what else would I look for? So for this, the biophysical profile, the other part of it is an ultrasound. And on the ultrasound, they look for breathing movements from the baby because babies make breathing movements in utero. The diaphragm still moves because they breathe in that amniotic fluid. They look at the baby's muscle tone and fetal movement. They do look at the amniotic fluid level as part of the assessment. It's not just one piece, okay? And so we take into consideration the fetal heart tracing plus all the things they see on ultrasound, and they give it a score. If the score is high, the baby's doing well. If the score is low, that could be a sign of potential fetal compromise. Okay. If the score is low and we're worried that the baby is in trouble, they might deliver. And we actually had a girl that worked in the clinic. They came in, she hadn't been feeling her baby move. And we did a non-stress test, and the non-stress test was not reassuring. So they did the biophysical profile, and the biophysical profile score was very low. And they did a C-section, and that, like right then, and that baby's 1-minute APGAR, I think, was a 2. The baby was in trouble. Okay. Upright positioning in the second stage of labor causes a 10 to 30 millimeter mercury increase in downward pressure. Why is this beneficial? Okay, so upright positioning is going to help with descent. Is it working now, Kimberly? Is everybody else's game working? Okay.
Yeah.
All right.
Yes.
So upright positioning is going to help with descent. It's going to help bring the baby down. All right. So when we say upright positioning in the second stage, what's the second stage?
That's the actual like pushing of the baby.
Good.
Like
Yeah.
active labor.
So what's the first stage?
Up to 6 centimeters.
It's going to be longer than that.
It's just up until
Can you repeat your question?
Let's do stages of labor real quick. What's the first stage of labor?
Like
Late
dilation.
phase.
It's going to be dilation. So latent phase and the active phases. So onset of labor to 6 centimeters is the latent phase, and then 6 centimeters to fully, or 10 centimeters is the active phase. So that's all the first stage, right? So onset of labor to full dilation is the first stage. What's the second stage?
Delivery of the baby.
Okay, so we're going to go from full dilation to delivery of the baby is second stage. So this game question was asking about using upright positioning for second stage. That's having her like squat to push to help bring that baby down. Okay, upright positioning is helpful in the first stage too. That's why we get them up and walking and maybe sitting on a birthing ball and things like that to help with descent. What's the third stage?
Is that the placenta?
To deliver the placenta. So from the time that the baby's out to the time that the placenta delivers is the third stage. And then what's the fourth stage?
Recovery.
And so it's the first 2 hours after the baby's born. Is the recovery time is the fourth stage. Okay. A woman is 36 weeks gestation. Which of the following tests will be done during her prenatal visit? All right. So we're going to check group B strep. All right. Is anybody familiar with what the group beta strep is and why we want to test for it?
Isn't it like bacteria that can pass to the baby during birth? And if you test positive, you have to have a C-section, right?
You don't have to have a C-section, but you need antibiotics. Okay,
Because it can pass
so
to the baby, right? In vitro, in birth, if they're not free, like on antibiotics.
right. So it's a bacteria. I'm sorry, guys. And it can live in the normal flora. And it can come and go. It doesn't bother us. I might be group B strep positive right now. I don't know. But if the baby delivers, the baby could contract it. And it has a high mortality rate if babies contract group B strep, up to 50%. So we swab the mom and we check to see if her group B strep is positive. And if it is, we give her antibiotics during labor so that the baby does not contract group beta strep. Okay. So every woman is going to be tested typically around 36 or 37 weeks. So we just give them antibiotics in labor. It's pretty routine. The glucose tolerance test, that's something that we would have done sooner. Okay, we do that around 24 weeks. What's the glucose tolerance test for?
Gestational diabetes.
Good, to rule out gestational diabetes. Okay, and then we already talked about amniocentesis a lot. What about RH incompatibility? We would want to do that at the beginning of pregnancy. We'll do a blood test. And what's
ROGAM.
important? Good. And who gets ROGAM?
The mom.
Okay, which moms get ROGAM?
The ones that are
negative.
positive,
The ones that are RH negative.
negative.
Yes. So RH negative, the problem that happens with RH incompatibility is mom is negative, and if the baby is positive, the mom's body does not recognize that RH positive protein. And so remember that maternal blood and fetal blood shouldn't mix at all. Once in a while, things happen that can cause the mom's blood to see the baby's blood, usually like trauma, but sometimes things with childbirth also can cause it to see it. If it sees it, it goes, that is not supposed to be here, and it makes all these antibodies. The antibodies will affect a future baby. Okay, but we're going to give moms that are RH negative ROGAM at 28 weeks so that if there's any bleeding things that happen throughout the pregnancy, it takes care of that so we don't build up antibodies during the current pregnancy. And then when the baby's born, they'll check the blood type. And if the baby's positive, mom will get ROGAM again to just prevent that antibody response. Make sense? Yeah? No?
Yes, it does.
It's discovered that a pregnant woman practices pica. Which of the following complications is most often associated with pica? Okay, this is iron deficiency most often causes pica. Do you guys know what findings we see with pica?
Don't they eat like dirt, clay, non-food items?
I'm sorry, I can't hear you very well. What'd you say?
They eat non-food items. They like crave them.
Yep, like dirt and clay and chalk and stuff like that. A pregnant client, this is that same pregnant client, okay? She's been pregnant 2 other times. She had twins that are 2. She had a miscarriage. What describes her gravidity and parity? So we discussed this with this question before. Do you guys remember? Good. So she is a multigravida because she's pregnant more than once. And she's a primipara because she's only had 1 delivery after 20 weeks with the twins. What would be the first intervention to try with an abnormal fetal heart tracing, such as late or variable decelerations? Okay, position change is a good first thing to do. Okay, and so with variables, what causes variable decelerations?
Not like when they're not getting enough.
Is it pressure on the umbilical cord?
Variables are
Oxygen.
pressure on the cord. And then if they're not getting enough blood flow through the placenta, that's what's going to cause late decelerations. So for either of these, a position change will help because if it's late and we're not getting good placental perfusion, position change might take pressure off the vena cava. Remember supine hypotension. And if it's variable decelerations, position change might take pressure off the cord. So either one, a position change is a good first thing to do. Well, the game is stuck. I haven't had that happen with this game in a long time. Oh, there it goes. A nurse working in a prenatal clinic is providing education to a client who's pregnant. The client does not like milk. What's a good source of calcium that the nurse can recommend? I think my internet's acting up. All right, the answer. Okay, moving on. 36-week gestation client lies flat on her back. Which of the following maternal signs or symptoms would the nurse expect to observe? Okay, so if she's laying flat on her back, she might have dizziness or lightheadedness because it causes hypotension. It causes her blood pressure to go down. The nurse is caring for a laboring client. Which statement indicates the client is entering stage 2 of labor? Okay, so this one, entering stage 2, remember we talked about stage 2 is from full dilation to delivery of the baby, so she's now having that urge to push. I feel the baby coming out now is also stage 2. That's probably not entering stage 2, that's the end of stage 2, but that is still the second stage. Yep. A cervical dilation is 2, 50%, and -1. The fetal heart tones are reactive and reassuring. What nursing actions would be appropriate for this phase and stage of labor? Okay, so we don't need to assess heart tones every 15 minutes. We'll probably just check in like once an hour with a Doppler. We don't need to check her cervix every hour. We don't need her to urinate every 1 to 2 hours, but ambulating is a good thing to do in early labor. Okay, so ambulating is going to help with that upright positioning. It's going to help bring the baby down. It's going to help with progress. It's also a good non-pharmacologic thing to have her be doing. So that's what we'll do is have her ambulate. The nurse is reviewing fetal circulation with the client. The client understands the teaching when which statement is made. Good. Fetal oxygenation occurs through the placenta. All right, so think about that for a second. Like, we're not using the lungs of the baby, right? So the oxygenated blood comes in through the placenta, the carbon dioxide goes out through the placenta. So it really functions like that for the baby. Fetal oxygenation occurs through the placenta. That's why placental perfusion is so important. Okay. Umbilical artery blood has the highest oxygenation. How many vessels are in the cord?
3.
3. What vessels do we have?
Two arteries in a vein.
One vein.
2 arteries, 1 vein. Which vessel or vessels have the oxygenated blood?
The veins.
The vein. The vein is the bigger one, and it is what is coming in with the oxygenated blood. The umbilical arteries are tiny, and they're taking the waste away. The nurse suspects umbilical cord compression if which is noted on the external monitor tracing during a contraction. Good. Okay. Cord compression is variable decelerations. All right. Variability is the squiggly line. Accelerations are those increases. Early deceleration is head compression. Okay, so if you're not sure, like write down veal and chop and follow it across. Which statement is true about exercise during pregnancy? Okay, so low impact is encouraged. All right, we're not really wanting to work on using exercise to control weight gain. All right, it's just going to be for their comfort and to just feel good. All right, we don't want them doing vigorous exercises. All right, so swimming, yoga, stuff like that is good. And it is taught to diabetic clients to do after meals to help control blood sugar. Which of these is not a probable cause of intrauterine growth restriction? Okay, so diet that's high in complex carbohydrates, that's exactly what we want them to have, right? To help grow their baby. Smoking and hypertension both cause vasoconstriction, which is going to affect the way they grow their baby, and some torch infections can do this too. Does anybody know what IUGR, intrauterine growth restriction, like what is that?
Is that where the baby's not developing correctly as far as like organs and stuff?
The baby will still, the organ should still develop okay, but we're gonna have they're gonna be small. They're not gonna be growing well. And it's because we're having a chronic circulation problem over time. So it's limiting the nutrients and oxygen that the baby's getting throughout the course of the pregnancy. So anything that's really causing a chronic vasoconstriction or vasospasms can do this. So hypertension, preeclampsia, smoking, all of those things can cause it. Intrauterine growth restriction, intrauterine is in the uterus. Growth restriction, the baby's not growing the way that we would anticipate. We can pick up on this by measuring fundal height. So do you remember with fundal height, when we measure fundal height, what we expect to find?
It should match with the amount of what is it called? Like the weeks? Or
Good.
yeah.
Yeah, it should be the same number of centimeters as the number of gestational weeks, plus or minus 2. So if you have a patient who's 34 weeks measuring 30 centimeters, that could be a sign of intrauterine growth restriction, right? Because it could be a sign the baby's small, that things aren't growing well. But it's going to be these chronic issues that affect circulation that really can contribute to this growth restriction and these small babies.
So similar to like when moms like drink and stuff like that, that their babies end up coming out like smaller than what they really should be for their.
So fetal alcohol syndrome has more cognitive issues for babies than growth issues. So different things can affect, like different substance use and things like that can affect a lot of other things, not just the way they grow. But most of the time, the ones that are going to affect the way they grow are going to have to do with the way the vasculature is being affected. So it just affects perfusion. So when we talk about preeclampsia affects a lot with vascular stuff, right? It has chronic vasospasms. It affects the way she perfuses her own organs and the way she perfuses her placenta. And smoking causes chronic vasoconstriction. So usually this is going to be typically more related to vascular type stuff. Which patient does not need a dietitian to assist in evaluating and planning nutritional needs during pregnancy? Okay. So guys, if you have a low risk uncomplicated pregnancy, you don't necessarily need to have a dietitian working with you. If you are a vegetarian or you have certain cultural food patterns, that can affect your intake of certain key nutrients that you need during pregnancy. So it's really a good idea for people with those kind of preferences to have somebody, a dietitian, help them navigate how to make sure they're meeting all of their nutritional requirements for pregnancy. And that's why even though vegetarians and different ethnicities with certain food preferences are probably still eating very nutritiously and are fine, it's good to just have a dietitian looking at all of it to make sure that they're hitting all of those key points. And then diabetics need to figure out how to eat healthy carbs because we still need carbs to grow a baby, right? But how to eat the right carbs if you're diabetic. And then adolescents have a lot of nutritional needs because their body's still growing and their body's using nutrients for their own growth before they give it to their baby. And then they also have higher prevalence of iron deficiency anemia and things like that. So all of these will benefit from a dietitian. Does anybody know normal weight gain if you have a normal BMI?
25, 35.
Is it
Right,
no more than
Patricia?
25 pounds?
25 to 35 total is normal. And the first trimester, how much do you think they gain in the first trimester?
About 10 pounds?
It's going to be less. So the first trimester is going to be the first 12 weeks. And during that time, there's a lot of stuff happening inside the fetus as far as all of those building blocks to grow all these organ systems. But there's not a lot of actual size happening yet. And also, this is usually in the first trimester when moms might have nausea and vomiting and pregnancy and stuff like that. They really only gain about 1 to 4 pounds in the first trimester. But after that, it's about half a pound to a pound a week the rest of the time for a total weight gain of about 25 to 35 pounds. A client's fundal height is noted to be at the xiphoid process. The nurse is aware that which of the following fetal changes is likely to be occurring at the same time in the pregnancy. So this question really, you got to really think about it. So I really like it because you have to think it through. If the fundal height is at the xiphoid process, how far along in her pregnancy do you think she is?
She has to be closer to then.
She should be closer to the end, right? Because when do we start measuring fundal height?
After 16 weeks. No,
Little bit, it is after 16 weeks, a little bit. It's going to be about, oh, go ahead, Lanisha, what do you
20,
think? About 20 weeks is when we start measuring fundal height. And at 20 weeks, where do we expect to find the fundus?
by the umbilicus,
Yep, by mom's belly button, the umbilicus or the umbilicus. Okay,
umbilicus.
you can say it either way. It's actually correct either way. All right, so if we're measuring at 20 weeks, we expect to find the fundus at the umbilicus or the umbilicus. If we're above that, we're further along in the pregnancy. So if we're at the xiphoid process, we are really close to the end, right? We're out of room. So if we're close to the end of pregnancy, then if we look at the choices, heart begins to pump blood. That happens in the first trimester. Eyes begin to open and close, happen in the second trimester. Spinal column closes, that happens in the first trimester. Surfactant is formed in the fetal lungs, that happens towards the end, right? So surfactant is that slippery substance that helps those alveoli stay open for the baby once they take those first breaths when they come out. And so they don't form their surfactant towards the end. So like when we talk about preterm labor in week 6, I think, that's one of the considerations is, do we need to give mom medicine to help increase surfactant production for the baby if the baby's going to be born early because we don't have enough surfactant happening yet? Okay. For the fundal height, if we expect to find it at the belly button at 20 weeks, if she's less than 20 weeks, we're not usually measuring because it's harder to feel it, but it's going to be below the belly button or both below the umbilicus, right? We can't even really palpate the fundus until after the first trimester. It's kind of in the bony part of the pelvis until about 12 or 13 weeks. And then it starts kind of slowly inching up. All right. So if we're between 14 and 16 weeks, we're somewhere between the pubic bone and the belly button. And if we're past 20 weeks, we're somewhere between the belly button and the xiphoid. Make sense?
Yes.
Which of the following answers best describes the stage of pregnancy in which maternal and fetal blood are exchanged? Good. This is kind of a trick, right? Because we don't exchange maternal and fetal blood. All right, they're never exchanged. So the answer is yellow, and you guys all got it. A pregnant client, this is that same girl again. It wants to know her due date using Nagel's rule, and we figured this out before. Do you remember? Her last menstrual period's 12/1/18. Using Nagel's rule, what's her estimated due date?
That was at 9/18/19. 9/8/19.
Yep. 9/8/19. Good. The nurse realizes that the most common and potentially harmful maternal complication to epidural anesthesia would be what? Okay. So when the beginning of today, when we talked about fetal monitoring, remember we said that what do we purposely do for laboring women that can cause hypotension, and it's the epidural. So when we give her an epidural, it causes her body to have vasodilation, and that causes her blood pressure to go down. Is that going to affect perfusion to the baby? It will. So what could we do for this mama who wants an epidural right now to try to limit the amount of hypotension that could happen so that we keep perfusing the placenta well?
Would you give her fluids?
Give her fluid bolus before we even do the epidural. Good. Yep. Which of the following clients should the nurse be concerned about regarding weight gain? Well, we just talked about weight gain. Okay. So based on what we talked about, if this client gained 15 pounds in her first trimester, that's not normal. Okay, so we're concerned about that. Client who gained 4 pounds in her first trimester is normal. A client gaining 20 pounds in her second trimester is normal. And one that has gained 25 pounds in her third trimester. All three of those totally fit what we just talked about, right? With the 1 to 4 pounds in the first trimester and then a half a pound to a pound a week. But this girl gained 15 pounds the first trimester. That's concerning. So we need to figure out why. Which is a sign labor may begin soon? Okay, this one is bloody show. Bloody show doesn't necessarily mean she's in labor, but it can be an indicator that she might be starting labor soon. As the cervix starts softening for labor, it can cause the capillaries to break a little bit, and she can have a little bit of blood on her tissue. She also might lose her mucus plug that could have some blood in it as well. All of that is indicators that labor might be starting, but it doesn't mean she's in labor now. The nurse would teach a client to report all of these except which one, and that is not a warning, not considered a warning sign of pregnancy. So which one of these is not a concerning thing? Everything else we would want her to report. Okay, urinary frequency, normal, right? Normal with pregnancy, especially in the first and third trimester. Heartburn or epigastric pain with a headache, what might that be? Any idea? If we have this headache and we're also having this epigastric pain, ugh, I just feel bad. So in the chat, we have preeclampsia, and that's what it could be. Okay, it's normal to have headaches in pregnancy, and it's normal to have heartburn in pregnancy. But if we're kind of having both and we can't relieve the headache with treatment, I'm a little worried that she might be preeclamptic. So we'd want her to just let us know. How could I know? Like, we spend way more time on this later, but how could I know if she's preeclamptic? If she comes in and she is feeling like this, what could I do to find out?
Urine test. Oh, blood test.
Urine? Well, no, you're right. We could do a urine test. We could check and look for protein. We can also just take her blood pressure. Okay. Yeah, check vital signs in the chat. So any of those would be good ideas. So she might have normal things, but if we just take a blood pressure or we check her urine for protein, we would know. So we would want her to report that. If she's leaking fluid, we would want her to report that. Unless she's term, maybe it's her water breaking. But actually, I still want her to report it because if her water breaks, she should come to the hospital. If she's bleeding, we want her to report that. But urinary frequency is normal. Is there anything else like you would want her to report? What other things would we teach her to tell her provider if she was experiencing that could be concerning or a warning sign?
Can you repeat your question?
So I just was going to expand on this idea here, and I asked, what other things would we want her to report that might be warning signs in pregnancy besides the headache that's not going away with epigastric pain, leaking fluid, vaginal bleeding? What else would she
Swelling.
say that again?
Swelling. Like
Okay.
feet, hands, face, stuff like that.
Well, and some
Retaining.
swelling in the feet is kind of a normal thing, right? But if she's got a lot in her hands and face, that would be weird. So that's a good idea. What else?
If the
Like signs
baby's
of
not
a
moving.
UTI.
The baby's not moving. Yep. If she's not noticing fetal movement, that would be important. Glenisha, what did you say? Something about a UTI?
Signs
No,
of a
I said,
UTI.
yeah.
Okay. So if she has like burning when she pees, also flank pain, because even worse than a UTI would be like if she develops like pyelonephritis. So signs of UTI or flank pain would be good to report. Maybe contractions if she's preterm. Severe vomiting. So there's one thing like nausea and vomiting of pregnancy happens, but if she's like very severely vomiting, like hyperemesis gravidarum, she should probably tell us that too. All right. The client assumes she's in labor. Which assessment findings would indicate the client is in true labor? Remember the girl earlier that was 5? We said, how do I know she's in labor? So I'm going to know for sure she's in labor if what? Like, how do I really know for sure she's in labor?
If the pain continues to intensify, or the contractions rather.
So that can be a sign of true labor, that it's getting worse, even with comfort measures. But how do I really know she's in labor? For sure.
Cervical change.
Cervical change. Okay.
The
So
cervix.
as far as what's happening with her, so that's why it's not blue. Cervix doesn't dilate or efface, then that's not how I would know she's in labor. Discomfort localized to the abdomen. It's usually going to be in the low back and radiate to the abdomen. Contractions decrease with frequency, in frequency with the ambulation. Usually it will increase with activity in true labor. And so the way I really know is if her cervix is changing. But as far as the way her contractions present, if comfort measures help, like I put her in the tub, I give her the jacuzzi, right? Or I have her ambulate for a while and her contractions feel better, it's probably not labor. But if they're increasing in frequency, even with comfort measures or activity, it's probably labor. And then the pain in the low back that radiates to the lower abdomen and even sometimes down the thighs as well. This genetic disorder is going to happen if both parents carry the gene. The baby has a 25% chance of expressing this genetic disorder. So it could be things like cystic fibrosis, sickle cell, I think is also one. So this is going to be recessive genes. Okay. With recessive genes, the parents don't have the condition, they carry the condition. And they both have to carry the condition in order to create a baby that has it. Okay, so genetic disorder in which both parents must be carriers of the gene in order for the baby to have a 25% chance of expressing the disorder. Those are recessive genes. 5 more questions. Woman in labor is 6 centimeters dilated in 0 station and contracting every 4 minutes, and she asks for an epidural. In order to limit the risk of this procedure to the mom and the baby, the priority intervention before the epidural is to give fluid. Okay. Monitoring the fetal heart rate is also going to be an important thing to do, but that's not a priority intervention to limit the risk of the procedure. Okay. So we're preloading with fluids to help minimize the risk of that hypotension that we talked about before. A woman in labor is 580 and -1. The baby is LOP. The most appropriate nursing intervention to promote comfort and facilitate progress of labor and delivery is the baby is occiput posterior. Okay. So she's 5 centimeters, 80%, so almost all the way thinned out, -1 station, so the baby's still just above the ischial spines in the pelvis. The baby is occiput posterior, which means that the baby's face is facing towards mom's front. That can cause a lot of pain in her back. So having her get on her hands and knees is going to create space in her pelvis to try to give that baby room to rotate. And it's also going to take pressure off of her back so the baby's head isn't pushing on those nerves in her back. So hands and knees would really be beneficial for her. A client at 36 weeks complains of discomfort and irregularly occurring contractions. What would we tell her to do?
Some wipes because you don't know.
Okay, so if she's having irregularly occurring contractions, those are probably what kind of contractions do you think?
Braxton Hicks.
Braxton Hicks.
Yeah. So let's have her walk around and see if they'll subside because she's uncomfortable. Because usually Braxton Hicks will subside with ambulation. A nurse working in a prenatal clinic is providing education to a client who's pregnant. Oh, we already did this one. The client doesn't like milk. What good is a good source of calcium? So guys, if you have a patient that has aversions to certain things, we don't want to rely on prenatal vitamins for them to get all of their nutrients. So we would find other things that have those nutrients in them and encourage them. So for this, dark leafy greens, chia seeds are high in calcium. So we would try to find other dietary choices to help her and not just rely on her prenatal vitamins for nutritional purposes. What's the best way to support a laboring client coping well with contractions? Okay, so this is good. Speak to her between contractions. The thing with women when they're in labor is they really need to focus during those contractions. And so unless we're having like a big deceleration or something like that, I am not messing with that. I'm letting her breathe through her contraction, keep her focused, and then I'll talk to her in between. So asking questions or position changing or anything, we'll try to do it in between. If she's coping well, I don't need her to rate her pain on the pain scale. I don't need her to do any of those things. I'm really not having her partner make decisions for her. She can still make decisions for herself, and I'm not pushing the epidural. I'm just going to help promote what's working for her now. Fetal heart deceleration caused by uteroplacental insufficiency. Good. So these are the late decelerations. If we have placental insufficiency or uteroplacental insufficiency, these are the late ones. These are the worst ones. What should we do?
Change position, normal breather, the IV fluids, point.
Yep. Position, oxygen, IV fluid, notify, and either potentially do a tocolytic or turn off the oxytocin to decrease contractions. Just remember with lates, it's either probably blood pressure. Mom's blood pressure is not perfusing the placenta well. mom's position, which still is affecting the blood pressure to perfuse the placenta well, or it could be that we're having too many contractions because every time that muscle's squeezing, we're not getting good blood flow. Okay, good. Nice job, guys. That was a really long game. You guys did a great job. Any questions about any of that stuff? Or any of the other stuff? We talked about a lot of stuff. Feeling good? Okay, I'm going to stop our recording.